Okay, ooh, this is loud. Welcome, everyone, to the industry-sponsored symposium this afternoon. I'm so grateful to have you all here. We have a great expert here to talk to us today. Couple of housekeeping items. In your booklet that you picked up on the way in is a card that has a QR code. That is going to be where you can enter questions at the end or during the presentation to get asked. Those participating online, there's going to be a QR code at the end of the slide deck. And so if you can jot down your questions and then enter them, we'll get them there. So I am so excited to introduce Dr. Shorencentis today. He is a renowned expert in therapeutic drug monitoring. He is a psychiatrist and attending at the Department of Psychiatry at the University of Zurich and an associate professor at the Zucker Hillside Hospital in New York City. And he's here to share his expertise on therapeutic drug monitoring. So thank you for being with us and traveling all the way across the ocean to bring us all of this exciting updates today.
Thanks so much.
Oh,
I'm going to
you'll
use
need
a
this.
thing. Yeah. Can you hear me? Perfect. Thank you. So it's a really great pleasure and a privilege to be here. Earlier this day, I read AAPP, where pharmacy and psychiatry meet. I wonder, are there any psychiatrists in the room? I feel a little bit lonesome, but it's perfectly okay. So, needless to say, I value the interdisciplinary work between clinical pharmacists and psychiatrists. I think this is actually what makes me feel sure in my everyday life whenever I come to the limits of my knowledge and my understanding of what's going out there with the patients. These are my conflicts of interest. I am a psychiatrist. I perform TDM, I measure levels in my everyday life, and I'm really excited to share my knowledge of how to use, of how to make it valuable, clinically valuable in the everyday life, and particularly in the prescription of psychotropic medications and antipsychotics. This is an overview of what you will be hearing over the next minutes. Therapeutic drug monitoring, so this is actually like the formal term for measuring levels, also known as TDM. I'm going to be talking a little bit about the key concepts, and then we'll take it from there and talk of how to integrate it in the patient management. And in the end, I'd like to discuss that there are some challenges of how to deal with TDM in clinical in the clinical decision-making process, and also how TDM can be a game changer in the treatment plan development. So let's go back to the basics. Whenever we prescribe a medication to a patient of us, we have these diurnal fluctuations. And what we actually measure in clinical routine, or what we aim to measure, is the so-called trough levels. So it's the minimal value in the diurnal fluctuation. And this is right before the next intake of the medication that we prescribe. If the patient keeps taking the medication for 5 times the half-life of the medication that we prescribe, then we have what we call a steady state. Steady state is a balance, is a kind of an equilibrium between the amount of the drug that enters the body and the amount of the drugs that gets eliminated. So this is steady state. And whenever we decide to adjust the dose, the daily dose, that happens again. It takes 5 times the half-life till the patient reaches steady state again. Needless to say that whenever we have a medication with a longer half-life, it requires longer to reach steady state. Whenever we're prescribing something with a shorter half-life, it requires less time till the patient reaches steady state. So trough levels, steady state. So these curves actually depict more or less the pharmacokinetics of orally prescribed medications. Now, spoiler alert, in psychiatry, we also prescribe LAIs, long-acting injectables. They are actually getting increasingly prescribed out there, and I think the next generation of psychiatrists will have to deal with LAIs more than the older ones. And then things look a little bit different. But what these two application forms share is the notion of a therapeutic reference range. A therapeutic reference range is somehow a window within which we expect the ideal combination of effectiveness and tolerability. And Therapeutic reference range consists of a lower threshold below which we expect limited effectiveness and an upper threshold, Megan was talking about that as the point of utility, above which we expect no additional clinical benefit and in fact maybe an elevation in the risk of side effects related to the medication that we prescribe. Where the risk gets essentially higher is when the patient's levels cross the so-called laboratory alert level. This is invariably twice as much as the upper threshold of the therapeutic reference range, and this is where clinicians need to get additionally vigilant about the risk of side effects. So let's just sum it up. 3 things. Trough levels, which are the minimal values in the diurnal fluctuation, steady state, 5 times the half-life of the medication that we prescribe, and the therapeutic reference range, which is the window within we expect the best combination of effectiveness and safety. We set together the American Society in Clinical of Psychopharmacology and the TDM task force of the German analog of the ASCP, which is the AGNP, and we came up with an overview of therapeutic reference ranges for antipsychotics, also classifying them to antipsychotics where TDM is strongly recommended, and these include Clozapine, olanzapine, and that also having antipsychotics where TDM is recommended. You'll find here some of the most commonly prescribed antipsychotics like risperidone, paliperidone, and quetiapine. And then antipsychotics where TDM is useful, and asenapine for which the data is actually pretty weak and TDM is potentially useful. So we acknowledge that TDM is not equally recommended for all medications, for all antipsychotics, but for some of them we really have robust evidence strongly suggesting using TDM, measuring levels in clinical routine. Now, regardless of the antipsychotic prescribed, I picked up some indications where I really find TDM an absolute masterpiece of an instrument in clinical routine. And these include adherence, which is one of the indications for which TDM over the years has been extremely good established. And adherence is the elephant in the room when it comes to the assessment of treatment outcomes. It's a major issue when it comes to the prescription of antipsychotics. Additionally, the lack of response once we have prescribed standard recommended daily dosages, and then the management of side effects, but also in the long run, in the maintenance treatment with antipsychotics, for example, to prevent relapse and recurrence of psychotic symptoms, and also the determination of the patient's own individual personalized reference range. And I'd like to talk about that a little bit more because the majority of clinicians tend to wonder, so if the patient is tolerating the medication well and is responding, why would I bother to measure levels? And here's the point. Once you do have this kind of ideal situation, you prescribe the medication, the patient is responding, is tolerating the medication well, everybody's happy. This is a moment to perform a baselining. Having several measures at this kind of situation, you can come up with his or her own individual reference range. We're not all the same. So when you have that, you can use this on the long run in the maintenance treatment with antipsychotics. And this is because our patients frequently get older, they get prescribed other medications, they develop physical or other kind of comorbidities, and clinical outcomes change. So whenever you have a change in the clinical outcomes, it's important to go back and have these baseline values as a compass and see if a change in the pharmacokinetics, if a change in the values may explain the change in the clinical outcomes. And accordingly, you can then adjust the dose. You can decide for a switch or an augmentation or whatsoever. But this is why it is important to have a good baselining. It's important to have the patient's own individual reference range. Some additional valuable indications where TDM can be very helpful. I already mentioned drug-drug interactions, and not just the drugs, not just the medications. The online access to over-the-counter medications has increased exponentially over the years. It's sometimes impossible to get an overview of what our patients are taking, and our patients wouldn't even think about mentioning it because they don't consider them drugs, they consider them as support or something like that. But if you do some regular monitoring, you can have an overview on an interaction potential and also switching between generic forms. Some additional indications for TDM in clinical routine include genetic abnormalities. This mainly refer to the activity of liver isoenzymes, which impact the bioavailability of the medications that we prescribe. In this kind of situations, we talk about poor or ultra-rapid metabolizers who invariably need different dosing patterns compared to the average, if there's such a thing, to the average patients. Additionally, abnormal weight, obesity is pretty common in our patients, particularly in the context of antipsychotic treatment, differential ethnicity, and moreover in the treatment of particularly vulnerable subgroups like women in the pregnancy and lactation, children where TDM was originally introduced as part of pharmacotherapy, elderly patients, and patients with intellectual disabilities, but also forensic cases with a different type of rationale though. And last, I already talked about the physical comorbidities, the changes in the kidney function and the liver. These kind of things happen in the long run. Cardiovascular diseases and inflammation processes in the acute or chronic form, but also bariatric operations for which our patients are very frequently candidates. So these are the kind of situations, and I think these are really many situations where having monitoring, where measuring levels regularly can be particularly valuable. So this is how it should look like. This is a figure of how we envision TDM measuring levels in clinical routine. Remember, TDM is a problem-solving tool. I need a question. So once I have identified the question, I have the indication, right? Then I need to make sure I have a trusted, you use the word trusted, I like that, a trusted laboratory. So I need to trust what's coming back. Ideally, I should also have some kind of pharmacological advice. And I would personally add, I would like a reasonably short turnaround time. And that's particularly important because we need to integrate this information soon enough in the decision algorithm. I'll talk about that in a minute in detail. Now, wheels off. This is the TDM request. We have the information we need. We have the indication. It can be a routine monitoring indication, so it can be like a dose titration story, or in the long run in the maintenance treatment with antipsychotic, or it can be a specific type of indication. It can be a suspected drug-drug interaction. It can be a management of side effects, or it can be the lack of response to recommended daily dosages. So we do have the indication, and the next thing we need to do is to ensure steady state. Well, doesn't have to be always the case, particularly when we manage side effects. Then we need to make sure that we have trough levels, and then, as long as we have the lab to do the tests for us, we get the results back, hopefully in a reasonably short turnaround time. We get the information in moment of truth. We can use this information to make the decision, and this can be to adjust the daily dose, this can be to augment, switch, or whatsoever. And this is not the wheels on moment. This is actually a loop that goes on and on until the original question, the indication, has been sufficiently answered. So this is a process. Now, I said before I'd like to talk about the turnaround time, and it's actually really important for me. I'm curious, what is the standard turnaround time in your hospitals? 5 days, 6 days? 7 days? 10? Somebody said 10? That wins? Anybody longer?
You get a free ice cream.
So it's 5 to 10 days, I want to say. This is where I think, is that really useful if it comes 10 days later? I mean, how do I use that if I get that information 10 days later? No offense, right? But it's important for me to have this information as soon as possible. And we highlighted that aspect in a paper we published earlier on this year, that it's really important in situations such as like when you have unusually high levels of clozapine, the management of infections in antipsychotic treated patients. And I'd like to talk a little bit about that because we now have robust data that the leading mortality cause in clozapine-treated patients are respiratory infections. So against all expectations, they don't die of agranulocytosis, probably because all of us are overtly alerted about that, but they die out of pneumonia. So these are the kind of situations where I need to have all information available in order to be able to prolong the life of my patient. Other kinds of situations where the need for short turnaround time is at least to me evident, requires the management of adherence, particularly in emergency setting, and also the management of adverse reactions where we urgently need the information for the regarding the levels. And when I talk about the short turnaround time and the need for a short turnaround time, actually I like the analogy to ECG. So just think of it. You're having a patient with a chest pain that shows up in an emergency setting. The cardiologist would first prescribe ECG. And now the technician comes and says, look, you can have the ECG, but you'll have the results in 10 days. So how useful is that, right? I mean, this is not anymore an information that dictates action. It's a confirmation of the action in retrospect. So it's a proof of concept. It's not clinically useful to me if I cannot use this information right away. So it tells me I need to send the patient back home and call him back in a week or two to make a decision. That's not how it works in an emergency setting, but also in less urgent situations. I need the information, and I really need to make sure I have it as soon as possible back in my desk. So I already talked a little bit about how to get TDM in the patient management, but I'd like to delve into it more in detail. Adherence remains the elephant in the room for me, and TDM is so well established when it comes to the assessment of adherence. This is a really beautiful study from a New York hospital back in 2016, where clinicians were measuring levels in antipsychotic treated patients in an emergency setting who were admitted with a psychotic relapse. Now, surprise, surprise, 2 out of 3 patients were having levels below the therapeutic reference range, below the lower threshold of the therapeutic reference range. In other words, 2 out of 3 patients were not taking their meds or they were underdosed. And that raises the question, how many of these admissions could have been prevented if clinicians or if patients were regularly monitored for adherence and for the levels? So, and again, I think this is a really major confounder when it comes to treatment outcomes and assessment. So we looked a little bit more into that. To make a really precise assessment of adherence, you need several measures. I think that's the secret there is you need several assessments. You can barely make a good judgment of adherence using just one single assessment. That's not going to work for several reasons. Now, when you do have several assessments in your clinical routine, you might expect fluctuations up to 30% between assessments. That's actually within the range of the expectable. But when it comes to fluctuations higher than 50% between the assessments, this is where we have strong evidence, strong indication of adherence aspects. We went on to look into this topic in more detail when it comes to clozapine, and we reviewed TDM evidence for adherence assessment. The key concept is pretty much the same. Fluctuations in the dose-corrected levels of clozapine, more than 50% in repeated measures. Again, it's really important to have several measures before you can make an absolute judgment on that. Are a good indication, are a good index of adherence problems. In other words, for the same dose, if the concentration fluctuates more than 50%, there's a problem there. We also came up with some evidence on the role of the clozapine or clozapine ratios, having within the same patient a change in the ratio towards less than 1 is a good index of adherence problems. And obviously, the intuitive one, undetectable clozapine plasma concentrations. And now I'd like to talk a little bit about drug-drug interactions, which, as I said before, do not always involve drugs. But this one does. We looked into our own data set. This is a data set of risperidone-treated patients. So we had a group of patients with a risperidone monotherapy and 3 co-medication groups. In other words, groups where risperidone was combined with mood stabilizers, valproate, carbamazepine, and lamotrigine. Now, all these 4 groups had the same daily dose of risperidone. When we talk about risperidone levels in clinical routine, what we actually mean is the sum of risperidone, the parent compound, and also the main metabolite, which is 9-hydroxyrisperidone, also known as paliperidone. So ultimately, we use this is called active moiety. It's the sum of the parent compound and the metabolite. Now, keep in mind that despite these four groups had the same risperidone daily dosages, what happened is that if you look at the co-medication with carbamazepine group, they had almost the half of risperidone active moiety levels. And this is because of the inducing effects of carbamazepine. Carbamazepine is a notorious inducer. It accelerates the clearance of several medications, including risperidone. Take-home message, if you want to combine risperidone with a mood stabilizer, don't consider carbamazepine. And this is an easy thing to catch if you measure levels. Ultimately, you want to have a combination treatment that works, and that's not going to be the case if you combine these two. And as I said before, sometimes interactions are out there, although they don't involve drugs. This is a literature review that we did earlier on looking at clozapine and combined oral contraceptives. This is a frequently overseen type of interaction. Combined oral contraceptives contain ethinyl estradiol, which affects several metabolic pathways. We looked into the available TDM data, and what comes out, we estimated a dose correction factor, which is 0.5, and practically means that if you want to prescribe clozapine to a woman who regularly receives combined oral contraceptives, you'll need the half of the dose to avoid clozapine overdose. Another kind of interesting interaction refers to caffeine, although it's important to say that several serious amounts of caffeine are required. Here's a case, a really beautiful case report published a couple of years ago with a 34-year-old patient with clozapine with a stable dose of 400 milligram a day. He was found stamped against the wall on the floor, obturned tachypnoic with a Glasgow scales of 6, energy drinks all over the place. I've been told they give you wings. Was not the case. 6 energy drinks. She was actually trying to treat the weight gain that probably was taking place in the context of clozapine. That's another case. That's a case where patients take over our role. So instead of having him or her doing what we should be doing, he takes it over. He thinks he's treating himself. He ends up with a clozapine level of 1,800. Practically, the clozapine metabolism was blocked, although the dose was actually kind of an expected dose. I'd like to talk more about TDM and clozapine. It is actually the antipsychotic where we have the best type of evidence. It's the antipsychotic where TDM, to my opinion, is an integral part of treatment and should be treated as such. Earlier on, Megan was showing a recommendation from a TRIP consortium. It's kind of an international consortium about treatment-resistant schizophrenia. Now, clozapine, 35 years since its approval by the FDA, remains the only medication that we have for treatment-resistant schizophrenia. In other words, it's one of the very, very few options that we have that's really actually miserable when it comes to not responding to other antipsychotics. And in fact, before we set the indication for treatment-resistant schizophrenia, we need to make sure it's not a pseudo-resistance. We need to make sure it's not a resistance due to adherence issues. We need to make sure the patient is taking the meds before we say she or he doesn't respond to that. So the TRIP consortium cited earlier before says that you need to at least on one occasion measure levels and see that it's not a pseudo-resistance case before you prescribe clozapine. So once you have done that, you have measured levels, and as I said before, you need a couple of measurements to make sure that this is an adherence problem. Then you set the indication for clozapine, and next thing you want to do is, once you start with clozapine, you want to reach the 350 nanogram per milliliter. So this is a value, here's the Canadian guidelines, but this is a value that is pretty much adopted from the majority of the guidelines worldwide when it comes to judging the effectiveness of a clozapine trial in 3 months or 12 weeks. And the reason for this unanimous adoption of this value is because we have robust primary data, and this is a meta-analysis from Dan Siskid, that points out that patients that do have clozapine levels above 350 nanogram per milliliter have 2.3 chances, double as much, even higher, to respond to clozapine compared to patients with clozapine levels below this magic number. So, and it's actually interesting because we do have very robust data when it comes to clozapine levels, but this is not the case when it comes to the levels of clozapine's metabolites. We had a heated discussion earlier on regarding the clozapine and the ratios, and I'd like to touch a little bit on that. So this is more or less the metabolism of clozapine. We have the main pathway that leads to N-desmethylclozapine, also known as norclozapine. There are also some additional metabolites that have received disproportionately less attention over the years. And we have several studies looking into norclozapine, but we need to say that the data is less robust. Here's a meta-analysis looking in the association between norclozapine levels and side effects. And what strikes the eye first is that the number of studies are small, and the size of the cohort studied has been really, really small. Now, that particular meta-analysis reported a difference or a role for these three side effects: elevated cholesterol levels, triglycerides levels, and weight gain. But again, what's really striking here is that the effect size is very, very small, and it's far away from getting a clinical value. We need more research if we really want to prove that there is something there, and I don't really know if this is the case. Now, part of the debate regarding the clinical value and the clinical utility of measuring norclozapine levels has been the notorious story of the metabolic ratios, clozapine to norclozapine ratios. And this is a debate that was, at least to my knowledge, first initiated back in 2015 by a Canadian group that suggested that there is a negative association between working memory performance and clozapine to norclozapine ratios. In other words, the higher the clozapine-norclozapine ratio, the worse patients perform in terms of working memory. Ever since, there have been several studies out there, and we tried to systematically review the literature and really see if we can identify a potential for the clozapine to norclozapine ratio when it comes to the judgment or a predictive role for the working memory performance or any kind of cognitive function. And the truth is that these values or these ratios are way too unstable and cannot be reliably used when it comes to the assessment of cognitive or working memory performance. So even within the same individual, the values were changing so strikingly that we do not think, at least for the moment, that they can be used as such. The whole debate, to me, got a little bit somehow settled when the same group that originally initiated the debate a couple of years ago published this paper acknowledging that the association between working memory performance and the clozapine to norclozapine ratio holds true only in a small subgroup of patients, and these were patients that were non-carriers of a genetic polymorphism, specifically of a cholinergic receptor muscarinic gene. So this is, if this really holds true, it has to be in a very, very small, over-selected patient subgroup. Now, I'd like to move to the last part of my talk and address some challenges when it comes to using TDM in clinical routine as part of a clinical decision-making process. And as I said before, I think it is a game changer when it gets to be part of the treatment plan development. So I mentioned before, this is a slide that I showed before. This is what happens in the body of patients when we prescribe the medication. We measure trough levels, but what frequently comes up is that how can we really measure trough levels if the patient is receiving a once daily dosing regimen at bedtime? So the easy type of situation is you're having somebody with a split or multiple daily dosing, a patient that gets prescribed a medication early in the morning, sometime in the afternoon, and at bedtime. So when you measure early in the morning, right before the next intake of the antipsychotic dose, this is trough level. This is perfectly trough level. The practical challenge is when a patient receives a medication at bedtime once daily. And this is because the majority of the inpatient units do not have around-the-clock phlebotomy service, and this is practically impossible in outpatients. So how do we do that? This is a at least to me, this is a very common type of challenge in clinical routine. In this kind of situations, to me, it's important to keep two things in mind. And the one thing is that if it's not trough, it's higher than the trough, right? As I said before, the trough levels are the lowest values in the diurnal variation. So if you're having something that is not trough, you need to think of trough as something even lower. That's the one thing. And then the other thing is that if you cannot ensure trough levels, you need to make sure that the time point of the blood test is consistent. It's always the same. You cannot compare levels in a patient that were once drawn early in the morning and that the next time were drawn sometime in the afternoon. That's not impossible. That's not comparable. So just these two things, in lack of trough, think of these two principles. First, aim for as consistent as much time point of blood testing in order to increase comparability within the same patient. And the second thing, non-trough levels are always higher than the trough values, the real trough values. We try to put all this information within a clinical decision algorithm that considers clozapine levels, response and tolerability information. And in this first type of scenario, when you're having a patient that has levels of clozapine lower than the lower threshold of the therapeutic reference range, if the patient is not responding, is not tolerating clozapine well, you need to manage the side effects first and then go slowly high with the dose, aiming for the reference range. Now, if the patient is not responding but tolerating clozapine well, which is what I would expect, then you can go high with the clozapine dose, aiming for the reference range. In the type of situation that the patient is already responding to clozapine despite having these low levels, but is not tolerating clozapine well, you will still need to cut the dose. In the ideal scenario where the patient is tolerating clozapine well and responding good to clozapine, you just need to sit back and monitor. Now, I'll probably skip this one for the sake of time, and I'll come to this one, which is my favorite one. What happens when patients are having levels above the upper threshold of the therapeutic reference range? Like, when do we get scared? When do we get concerned? And particularly, this one refers to the upper threshold of the therapeutic reference range. But what's even more interesting, what happens when you're having patients with levels above the laboratory alert level, 1,000 nanogram per milliliter. So in this kind of situation, if the patient is not responding well, is not tolerating clozapine well, you need to cut the dose, you need to monitor, but you also you should consider prophylactically prescribing an anti-seizure medication. And this is because we do have data that suggests that the risk of clozapine-related seizures is elevated in patients having particularly high levels of clozapine. Now, what kind of anti-seizure medication? I think this is a decision that needs to be made on an individualized basis, but I would, for example, definitely avoid carbamazepine. As I said before, it's a notorious inducer. It's important to keep an eye on the whole panel. And then if the patient is not responding, despite having these doses, but he's tolerating clozapine well, what I would do, or what we suggest, is you still consider augmentation and specifically prophylactically prescribing an anti-seizure medication. If the patient is responding well but not tolerating clozapine well, you'll need to cut the dose and aim for the reference range. And in case that the patient is responding well and tolerating clozapine well, you should be highly vigilant about the risk of side effects, monitor, and again, consider prescribing an anti-seizure medication given the risk of side effects of seizures within the context of clozapine. Smoking is actually pretty famous when it comes to clozapine metabolism, has a very strong inducing effect on clozapine metabolism. But I still think this is a really interesting case report because it highlights the role of an unexpected type of drug-drug interaction. So this is a patient that has been taking clozapine for long enough, has a daily dose of 400 milligram a day, and a rather low clozapine level, which is expected within the inducing effects of smoking on clozapine metabolism. And the patient decides to switch from smoking regular tobacco to electronic cigarettes, vaping. I don't know how this is here. In Europe, this is really popular these days. Now, within 3 weeks after switching from regular tobacco to electronic cigarettes, look what happens, although the clozapine daily dose was stable, was unchanged. The clozapine levels explode to 3 times or even higher compared to the baseline. The patient developed side effects, hypersalivation, tiredness, obstipation, and EPS, and the clinicians had to cut the dose of clozapine. The clozapine levels get within the therapeutic reference range, and most important, there's the remission of side effects. So this is an atypical drug-drug interaction. This is a patient that we treated in our own day in clinic. It's a young female with a treatment-resistant schizophrenia with a rather high dose, daily dose of clozapine for the fact that she was a known smoker. She gradually complained about hypersalivation. The resident prescribed her pirenzepine. This is kind of a standard management option in Europe for hypersalivation. She only partially get better, but at some point, 2 weeks later, she developed psychotic symptoms. We, embarrassingly enough, we didn't have a baseline assessment of clozapine, but at that point, we measured levels, and she had 200 nanogram per milliliter. This is a subtherapeutic value, but it is also unexpectedly low for the fact that she was having a rather high daily dosage of clozapine. So what she gradually disclosed was that she had been taking clozapine irregularly, trying to self-treat the hypersalivation. That's another type of scenario where the patient takes initiative to do what the physician hasn't been doing. She has been treating herself. Now, the next thing we did is we started with a levels-oriented dose adjustment, and we ended up with 350 milligram a day, which led to a clozapine level of 602. It's right on the verge of the therapeutic reference range. And the most important is she didn't have any psychotic symptoms anymore, and she didn't suffer from hypersalivation anymore. And these are the kind of side effects that are pretty common in clinical routine, and they have a very deleterious impact in the life quality of our patients. This was, in fact, the reason that we decided to go and look in retrospect in a larger sample of our own hospital. So we actually picked out the patients that were having hypersalivation in the context of clozapine treatment, and we wanted to compare them to patients that were tolerating clozapine well. Now, interesting thing, the daily dose of clozapine was statistically significantly higher in the hypersalivation group. They were having 350 milligrams a day in average, whereas these patients had 300 milligrams. So this is statistically significant, but to my clinical experience, that was clinically minimal. 50 milligrams additional of clozapine, it doesn't really make a big difference. The striking difference is when you get to observe what happens with the levels. So if we draw a line right where the upper threshold of the clozapine therapeutic reference range is, which is 600 nanogram per milliliter, see what happens. The vast majority of the patients tolerating clozapine well had levels below this value, whereas around 1/3 of the patients suffering from clozapine-related hypersalivation were having levels above that value. And this difference gets even more striking if you draw a line at the laboratory alert level. This is 1,000 nanogram per milliliter. You'll see one single individual out of 323 in the group of patients that were tolerating clozapine well, where you see 9 patients out of 72 patients with hypersalivation who had levels above the laboratory alert level. So I think that there is a major role there, and there's a predictive potential to prevent, apart from managing this kind of side effect. And another type of side effect where we do have a distinct pattern when it comes to clozapine levels is the risk for seizures. I mentioned that a little bit before. That's an early review from 2011. It's a small number of patients, but it is what it is. But what you will clearly see here is that all patients were having astronomical levels, and in some cases, twice as much as the laboratory level, so the laboratory alert level. There is a clear pattern there that needs to be addressed, and this justifies the recommendation to prophylactically prescribe anti-seizure medications in these patients. I'd like to save the last part of my talk for a subgroup of patients that are of particular interest to me. For rather personal reasons, I remember the first pregnant patient, antipsychotic treated pregnant patient that I treated as a resident. I remember going to my attending and asking, are we supposed to do something with the dose? And the attending said, look, don't worry about that. The OBGYN are going to take care of it. So then I reached out to the college from the OBGYN, and they ensured me that the GP is really looking into that. And I ended up understanding that the only person who was really concerned about that was the patient herself. And that can end up being a very lonesome journey. It doesn't have to be. This is what comes with a pregnancy, a bunch of physiological changes that refer to the activity of the liver enzymes, the kidney function, the changes in the body disposition, but also the plasma proteins. And it ends up being an interplay of physiological changes with a drastic impact on the bioavailability of the medications that we prescribe, ultimately changing the treatment outcomes, the effectiveness and the safety of the medications that we prescribe. And this is what happened. A patient that has been stable for a long time before pregnancy, being prescribed a stable antipsychotic dose, gradually when pregnancy kicks in, due to the physiological changes, the dose is not sufficient anymore, and the worst case scenario happens. We have a psychotic relapse during pregnancy. This is a small cohort from a Scandinavian register study in just 4 patients, but I think it goes on to kind of exemplarily show what happens as a result of the physiological changes if you don't adjust the dose for the pregnancy impact. There's a patient that has a cut in terms of clozapine levels of 23%, and practically this implies that you may have a stable person with levels within the therapeutic reference range that in the 3rd trimester will end up having sub-therapeutic levels. I'm trying to make the point ultimately that antipsychotic prescription is a multidisciplinary task, and it needs, just like anything else, also to integrate measuring levels as an integral part of it. You can call it measuring levels, TDM, whatsoever. To me, it remains the sole personalized treatment tool that we still have, we readily have out there. And for me, it actually also raises the question, why would you going to go blind when you can use a compass? Before I thank you all for the attention, I'd like to thank the wonderful Saladex team for having me here. And again, thanks so much for attending, for your attention.
We're going a little rogue. We're going to move this over here and make it more of a conversation so it doesn't feel so much there. But we had some great questions, and thank you so much for your expertise today. It's greatly valued. One of the things that I know many of us as psychiatric pharmacists experience is the non-smoking status in our hospital. So we get all of our patients good to go. They're not smoking. We got them on the right clozapine, and then they are going to be discharged. And inevitably, we know they have a desire to begin smoking again, or we know that's coming. And so do you wait for the outpatient psychiatrist to deal with that? Do you preemptively think about increasing the dose at discharge? How do you sort of handle that situation?
That's one of the most common challenges, that we all have the same type of interest, but we operate in a very fragmented manner, right? For me, it's really important right at the moment somebody gets admitted that we try to contact the person who's going to be responsible afterwards and make sure that there's a smooth transition from what takes place in the inpatient situation to the outpatient. This is a really important thing, just because also, the differences or the inducing or the lack of inducing effects of smoking are going to take a little bit of time, 2 to 3 weeks till they show up. So you really need to be in good contact with the people that are going to be responsible afterwards to ensure a smooth transition from the one to the other setting.
Yes, that, as many of us know, is probably the most difficult thing, is actually getting that provider on the phone or someone at that office to alert them to these things without just sending a discharge summary. So I know we're all struggling.
Absolutely. I stalk people, like I'm going to call them, I'm going to send emails. That's really important for me, because otherwise it's so fragmented, and it's kind of like in advance, you expect this to fail if you don't do that.
Yeah, that is great. There's a couple of things that kind of bled over between the two clozapine sort of talks today, and thinking about your perspective on how valproic acid might affect the metabolic ratio.
So here's the deal. I don't like it. I don't like that valproic acid for so many reasons. I still don't understand the way it interacts with clozapine. I've seen data out there that suggests that it's an inhibitor. Somebody else would say it's an inducer. They would say it depends on both. So it's one of the medications that I don't really prefer prescribing because it's kind of a black box. And additionally, when it comes to moving to ECT, if you think of ECT as a solution afterwards, it would be good if you would then discontinue valproic acid. Otherwise, it may affect the quality of the seizures within the context of ECT.
Correct.
So I'm not the person that would prefer valproic acid at the first place. I know it's out there. I know people do it. I think it's not a clear thing regarding the ratio. It's actually both. It can go both ways. It can reduce or increase the ratio.
Can you switch to the next slide, just so the people at home, if they need to enter a question, can?
Sure.
I don't know where we put the clicker. I apologize. For those at home following along, there should be a QR code. There we go.
Is that it?
Okay, they're perfect.
Thanks.
So we'll keep our conversation going, and as more questions kind of come along. There is an excellent scenario. So if you have a clozapine level, which is inadvertently drawn after the morning dose, right, maybe half an hour or so, is there a window of time that keeps that validity valid, or is that should just be completely disregarded? I think they're asking about absorption of clozapine.
Right. That's the thing. If you're trying to interpret one single assessment of clozapine, I think it's a little bit tricky. For me, it's always important to have 3-4 measures to be able to interpret. And you obviously always keep an eye on what's happening. So you end up treating the patient, you don't treat the levels. But for me to understand if that's important or not, I need to check the comparability to the previous values. So if I see a pattern over the assessments and all of a sudden there's something strange there, then it may be important or not. But this is a decision that needs to be made at this individual type of situation. I cannot say, it's like it's going to be 30 minutes or it's like a 60-minute story. We try to aim for, we aspire for the maximal type of precision. But I understand that in clinical routine, that's not always the easiest thing to do. So we just head for the closest time point to the...
Yes.
I'm sorry, I cannot answer that in a more concrete way.
No, it is. It's a very challenging thing, right? Unfortunately, phlebotomy was held up, right? Or then the person inadvertently got their medication because the nurse didn't know to have their blood drawn before the medication. We've all, I think, experienced.
Yeah. We had that several times. We just put an asterisk there, making the notification when interpreting this particular value, keep that in mind. And I wouldn't discard anything. I would just put it on the whole pattern and try to understand if this is important or not.
That's excellent. Thinking about levels, right? What if we have patients who are taking their clozapine all at night and we're looking for that 12-hour trough? When is the best time? Or do you do a 24-hour trough? What is the...
Look, we never get to do 24-hour trough. I now work in an outpatient unit. It's impossible. I cannot expect anybody to show up in the middle of night so that we can have trough levels. If you guys do it, I have respect for you. Now, we always aim for the latest time point possible. And again, you would expect that it's not always easy for outpatients. It's more, for me, as I said before, once we cannot ensure trough levels, it's more for me important to know that what I'm getting is not the real trough level, so it's going to be higher than what it really is, than the real trough level. And the other thing, we always try to stick to the same time point to enhance comparability between the different assessments we've done. We need more, and we need to make sure it's always at the same time point.
I think that's the most key important point. Same time point every time.
Exactly.
So we can compare. And hopefully you have an electronic medical record that graphs that really nice for you. I know that, sometimes in our state hospitals and things, we might have paper charts that we are doing as psychiatric pharmacists. Hopefully you have nice graphing
We do have that, yes.
Some of us do, some of us don't. So in pregnancy, do we have any thoughts about when clozapine levels might increase again after birth? How long do those physiologic changes?
Yeah, it takes up to 4 weeks till the physiology gets back to the baseline, to the preconception values. It's a very dynamic phase. And, the thing is that it's not very common. Let's face it, clozapine in pregnancy or during pregnancy, nobody's going to start clozapine during pregnancy. So these are the kind of patients that are coming to you with a wish to get pregnant. And I think this is really valuable because you get to join them in this journey all along. So you do have this shared decision-making process. These are highly functional women that benefit from having clozapine and are happy to be there, be with you, and having all this whole journey not being alone. So right after birth, I think it's a really dynamic process. I've had patients coming every 4 days for clozapine levels. They get obsessed themselves, like, can we measure again? I need to have a good overview of that. And it has been really valuable to get them monitor intensively. Experience-wise, physiology restores to preconception levels within 4 weeks or a month, something like that.
I think that's great. I think you hit on a great point of saying patients are very actively involved. When you can have levels in a routine way, they're involved in their care.
Yeah.
And it's not, so I'll call you in a week and let you know where you're making a decision today, and they're part of that plan.
Right.
And that's, I think, very key.
I had patients calling me to get to know their levels because we had a delay like 1 day, and they were like, can I just call you tomorrow to get to know my levels? Oh, sure, yeah, go on. And the other thing is, I don't know how this is with you guys, but not everybody gets prescribing clozapine, right? So not everybody gets the privilege to get clozapine. We psychiatrists are highly selective when it comes to which patients who are the ones that are going to get clozapine. We expect them to be reliable, at least moderately reliable, show up for the monitoring and everything. It's kind of a thing, you don't want to give it to somebody who's a black box. You don't want to give it to somebody when you know it can get toxic. So we, in advance, somehow over-select these patients. And I think these are the patients that we can actively involve in this process.
Yeah, I think it's hard, right?
It's always hard.
And there's lots of factors that go into it. One of the questions from earlier today even talked about, what if my patient always says no? And I said, just start laying the groundwork. Maybe it's not clozapine today, maybe it's not going to be the next time, but if you start sort of laying the groundwork, it's not a shock when you have to reach that point. And so, you'll start laying some of those initial conversations so that they know that this may come, and we'll get there when we get there.
Yeah. But this one is not an evidence-based strategy. What happens to me very frequently is when we run out of options, I frequently come up with choices. So we do have clozapine and we have ECT. What are you going to go for? And that's the kind of situation, let's face it, right? They're both stigmatized, but if anything, ECT is way more stigmatized than clozapine. So I do have many patients that are actually grateful to get clozapine in this kind of situation.
Yeah.
But that's not evidence-based, and please don't cite me out loud.
When do you get the first clozapine level?
So we published earlier this year a guideline, and you do this weekly. So you assess weekly. You need to make sure once you start a clozapine that within a week, the patient is not going to have unusually high levels. Because if this is the case, so if you go 25 milligrams wise every day on a Monday to Friday basis, on the end of the week, you may expect, that's what we estimated, a clozapine level of 140. Now, if this individual has levels higher than 140, there's something there. It can be a genetic abnormality, it can be a drug-drug interaction type, it can be an immunological reaction to clozapine. It just so happens that many of these patients will have elevated CRP levels as a reaction to clozapine, and within a week, I want to know where I am. I use this 140 nanogram per milliliter as a rule of thumb to see how I'm going to proceed. Like, do I go on with the same tempo, or do I have to hold? Do I have to slow down? And I do this every week, and hopefully within a month or a month and a half, I've reached the expected or the therapeutic reference range, and then I can make a decision based on the clinical outcomes.
That's great. How often are you?
1 week,
every week?
Yes, every week.
Every week, that's perfect.
And I tell patients in advance, it's not a surprise. It's not, look, surprise, surprise, we have to measure again. I tell them every week we will be coming in and we will be measuring.
Which would go well with our U.S. standards of getting your white blood cell counts every week too. So hopefully we don't have that forever. We're working on that here in the U.S. That's excellent. So here's a little bit of a question. when you think about how much would you expect, say, a 50 milligram increase in clozapine, would you expect that to bump the level? Is there an estimate that you could sort of provide?
Well, but this is kind of an average estimation, right? So it's just so frequently happens that everybody behaves differently, and this is what sets the the suspicion that maybe there's something special there that does not fit the regular pattern. So if you go 50 milligrams higher, I would expect something around like 50 nanogram per milliliter or something like that. But again, it depends on what kind of situation you are. Are you in a titration phase? Are you in the long run, in a maintenance phase where you have to adjust the dose just because the patient does not respond as much anymore? Is it the steady state situation? I think it's a little bit hard to understand.
Yeah. It's hard to
make an extrapolation of that.
Yeah. I'd like to ask you something. We're going to switch gears a little bit. We'll talk about my second favorite topic, LAIs.
Oh, nice.
Yes, that's LAIs. And drawing therapeutic drug monitoring levels for LAIs. Yeah. This is a consult I get routinely of maybe my medication's wearing off. Should I get a level? What do I do with that level? I think the LAIs as they're increasing. Yeah. It's becoming a challenge to think about, I don't know what I don't know. Yeah.
So I'm a big fan of LAIs, and I don't mind being cited up on that. They work. I mean, if I had something like that and one would offer me the option to switch to LAIs, I would say, of course, no, I want to do that. I want to have a medication once monthly. So now, at least in Europe where I work, we had two kind of challenges in the beginning. The one was with paliperidone palmitate. So there was this idea that you don't need a loading dose, you just need one injection in the beginning, 1 week later you get one. And our experience was that if you don't have an oral substitution, patients do not really handle that well. So what we ended up doing is putting people on risperidone oral and then gradually switch them to paliperidone palmitate. So the other thing, it's a little bit of a dirty little secret, is that we are particularly flexible with the dosing interval. I have right now, and I'm not proud to say that, I have more patients taking a medication which is originally thought as one monthly, like every 3 weeks instead of every 4 weeks.
Oh, we do it all the time. You're not alone.
There you go.
It's everybody's dirty little secret, but our trouble is getting insurance companies sometime to say that.
Yeah, because it takes more injections, so you have to justify the cost of more injections. So now here's the thing. When it comes to performing TDM and measuring levels with LAIs, I think you need to know when was the last injection. You need to know what I always expect my nurses to write down is where did they apply it. It was like gluteal, was it deltoid? I had so many obese patients that we were doing gluteal injections that we couldn't find any levels in the blood, and the nurses were swearing that they did the injection. So these are the kind, I want to know as much as it gets. I want to know the dose. I want to know when patients were switched to the medication. I want to know where do they apply the injections. And ideally, I want to have the levels measured right before the next injection. So if I have all this information, I know what to expect. Now, the most important thing to me is that these are medications with longer half-lives. So they can go on increasing in levels over months and sometimes over years. So if you're applying a medication that is applied every 6 months, you would expect the steady state to be reached like in 3-4 years or something like that. And unless you do have this monitoring process, I don't know how would you ever know how much this patient is receiving in his body or her body.
I am always getting that consult of when do I get a level, and so it's always important to know right before the next injection.
Right before the next injection, I want to know what's the dose. I want to know which injection that is,
and where they gave it.
And I want to know where they applied it, like if it's.
Oh, that's our big thing. Well, I know we are right against the time, and I want to thank everyone. If your question wasn't answered, we're going to hang out for a little bit and allow for some engagement. But thank you so much for coming and spending time with us at AAPP. We greatly appreciate it.